Welcome to CannaInsights. I'm Dr. Sang Park, a cannabis scientist at the Institute of Cannabis Research. This is actually my first time recording with my own voice for this channel, so I appreciate your patience as I navigate this new format. What I may lack in polish, I hope to compensate for with genuine enthusiasm for the research we will be exploring today. Before we begin, I want to emphasize that cannabis research is evolving rapidly, with new studies emerging constantly. What we are discussing today represents the current state of scientific discourse, not medical advice. Think of this as a conversation about where the science stands right now. Today, we are examining one of the most compelling areas in cannabis research, the potential role of cannabinoids in cancer treatment. This journey began in 1975 with the first reported anti-tumor effects, and the scientific landscape has evolved dramatically since then. To understand this research, we first need to establish our framework. Cannabinoids fall into three main categories: phytocannabinoids, which are naturally derived from the cannabis plant, including THC and CBD; endocannabinoids, which your body produces naturally; and synthetic cannabinoids, some of which have achieved FDA approval as medications, such as dronabinol and nabilon. What makes this research particularly fascinating is its complexity. The anti-cancer effects we observe aren't uniform. They vary significantly based on the specific cannabinoid used, the concentration, and the cancer type being studied. This variability presents both challenges and opportunities for researchers. Let me walk you through some of the most significant findings, starting with glioblastoma, one of the most aggressive forms of brain cancer. In 2006, Dr. Manuel Guzman and his team published groundbreaking work in the British Journal of Cancer. They administered THC directly into the brain tumors of 9 patients who had exhausted conventional treatment options. Despite the small sample size, the results were noteworthy. The treatment was well tolerated with no significant psychoactive effects, and 2 patients showed decreased markers of tumor cell proliferation. The preclinical work supporting this approach is substantial. Dr. Gelf, Roper, and colleagues demonstrated that THC at 1 micromolar concentration induced apoptosis, programmed cell death, in glioma cells, and animal models showed actual tumor regression. Additionally, a synthetic cannabinoid called JWH-133, studied by Dr. Sanchez and later by Dr. Alexander's team at the University of Otago, reduced glioma growth by 1% in mice and completely inhibited growth in the most aggressive grade 4 human astrocytomas. More recently, Dr. Trolfs and colleagues conducted a phase 1b trial using nabiximols, a THC and CBD mouse spray, in combination with standard chemotherapy. The results were striking. 1-year survival increased from 44% with placebo to 83% with cannabinoid treatments. These are the kinds of outcomes that warrant serious attention and further investigation. The research extends well beyond brain cancer. In breast cancer studies, CBD has emerged as a particularly potent compound. Dr. Anna Regrasti and her team at the Institute of Cybernetics in Naples compared various natural cannabinoids and found CBD to be most effective at inhibiting breast cancer cell proliferation. In their mouse studies, published in the Journal of Pharmacology and Experimental Therapeutics, CBD reduced tumor growth by a factor of 2.5. Laboratory data revealed that CBD demonstrates greater potency than THC against breast cancer cells, with an IC50 of 11 micromolar compared to THC's 24 micromolar, lower values indicating higher potency. However, the picture isn't entirely straightforward. Dr. McKillip's team at the University of Otago discovered that high doses of THC actually increased tumor volume in mice by 1.6 to 2-fold. Their hypothesis centered on THC's immunosuppressive effects, which may interfere with the body's natural cancer-fighting mechanisms. This finding underscores the importance of dosing and the complex interplay between cannabinoid and the immune system. Moving to melanoma, the results have been equally compelling. Dr. Blazquez and colleagues tested the synthetic cannabinoid JWH-133 and observed a 5% reduction in tumor volume. On the synthetic cannabinoid, WIN55-212-2 produced a 56% decrease in tumor size and critically prevented metastasis to the liver and lungs. Given that metastatic spread is typically what makes cancer lethal, these anti-metastatic properties are particularly significant. Lung cancer research presents an interesting case study in scientific complexity. The very first study demonstrating anti-tumor effects, conducted by Dr. Munson and colleagues in 1975, showed that THC could inhibit lung cancer growth both in vitro and in vivo. Dr. Pritz's 2008 research confirmed that THC could reduce non-small cell lung cancer tumors and prevent metastasis. Yet Dr. Hart's team at the University of Wisconsin found that at nanomolar concentrations, extremely low doses, THC actually accelerated lung cancer cell growth through EGF receptor pathway activation. This apparent contradiction illustrates why dose-response relationships are so critical in cannabinoid research. Dr. Anna Corastido and her colleagues at Complutense University demonstrated that cannabinoids induced apoptosis in pancreatic cancer cells. When they combined CBD with gemcitabine, the standard chemotherapy for pancreatic cancer, mice showed significantly extended survival. In prostate cancer research, Dr. Safaraz and the team at the Paul P. Carbon Comprehensive Cancer Center at the University of Wisconsin tested WIN-55-212-2 on prostate cancer cells with impressive results. The compounds induced cancer cell deaths and significantly inhibited tumor growth in mice. Importantly, they observed a remarkable reduction in PSA levels in the blood, prostate-specific antigen being the primary biomarker for monitoring prostate cancer progression. The breadth of this research extends to other cancer types as well. Dr. McKillip's work on lymphoma showed THC significantly reduced cell viability and increased survival in tumor-bearing mice. Studies on liver cancer have demonstrated tumor growth reduction, and research on kidney cancer has shown that synthetic cannabinoids can induce both cell death and cell cycle arrest. To understand how these effects occur, we need to consider the endocannabinoid system, essentially your body's endogenous cannabis network. This system includes CB1 and CB2 receptors. CB1 receptors are predominantly located in the central nervous system, while CB2 receptors are primarily associated with immune function. When cannabinoids bind to these receptors, they initiate complex signaling cascades. Interestingly, CBD often bypasses these traditional receptors entirely, interacting instead with targets like TRPV channels and the orphan receptor GPR55. The anti-cancer mechanisms are multifaceted, involving the induction of programmed cell death, autophagy, where cells essentially digest themselves, and anti-angiogenic effects that prevent tumors from developing new blood vessels. This represents a multi-pronged cellular attack on cancer. In terms of current clinical applications, FDA-approved cannabinoid medications like dronabinol and nabilon are already providing benefit to cancer patients, primarily for managing chemotherapy-induced nausea, vomiting, and appetite loss. Recent systematic reviews indicate that medical cannabis can offer measurable improvement in pain relief, physical function, and sleep quality. While these improvements may be modest in magnitude for patients undergoing cancer treatment, an enhancement in quality of life is meaningful. We must also address adverse effects. The most commonly reported side effects include fatigue and dizziness experienced by approximately 10% of users, though most develop tolerance relatively quickly. Clinical trial data reveals additional effects, including cognitive impairment, nausea, drowsiness, and attention difficulties at rate above placebo. Dizziness occurrence ranges from 9 to 28% above baseline, depending on study duration. The immunosuppressive effects of THC present a particular concern, as they may paradoxically promote tumor growth and metastasis in certain contexts. This brings us to a critical limitation. Despite the promising preclinical data, we still lack the large-scale, robust clinical trials necessary to draw definitive conclusions. The glioblastoma study involved 9 patients. Much of the breast cancer work remains in animal models. While this foundational research is essential, we need studies involving hundreds or thousands of patients before we can truly understand cannabinoids' therapeutic potential in oncology. Regulatory barriers compound these challenges. Cannabis remains federally legal in the United States, creating significant obstacles for research. Additionally, pharmaceutical companies show limited interest in developing therapies from a plant that cannot be easily patented. Looking forward, we are clearly still in the early stages of understanding cannabinoids' role in cancer treatment. The preclinical evidence is compelling, demonstrating anti-tumor effects across multiple cancer types through various mechanisms. For symptom management, we have established benefits that are currently helping patients. However, advancing this field requires large-scale clinical trials, standardized dosing protocols, improved formulations, and significant regulatory reform. The story continues to unfold, and as someone actively working in this field, I'm genuinely optimistic about where we will be in 5 to 10 years. Thank you for joining me on this exploration of cannabinoids in oncology. I hope I've conveyed both the promise and the complexity of this research in an accessible way. This narration format is new territory for me, but I've enjoyed sharing this science with you. If you found this discussion valuable, please subscribe to CannaInsights for more cannabis science content, and let me know in the comments what topics you'd like me to explore next. I will always eager to dive deeper into the research literature. Until next time, stay curious.